When I began researching the protracted series of crises in Haiti, I was a little overwhelmed. I found it difficult to think of a proposal for this unit's assignment, so I decided to think small. I wanted to find a gap in the existing humanitarian space and write a concept note that could benefit the vulnerable populations. For this assignment, I designed a concept note that empowers women living with HIV as community healthcare workers. This concept note outlines a peer-led intervention designed to train and deploy women living with HIV as community health workers in Haiti. By leveraging their lived experiences, this program turns women living with HIV from passive recipients of aid into active participants for change. The trained community health workers will be responsible for educating, screening, and supporting other women in their communities, thereby decentralizing essential health services and mitigating the impacts of structural violence. Grounded in established evidence on the efficacy of task shifting and peer education, this initiative seeks to build resilient community health networks that can withstand the ongoing national crisis. Haiti is often described as facing a polycrisis, where multiple overlapping emergencies reinforce one another and make recovery challenging. The 2010 earthquake and subsequent climate-related disasters destroyed infrastructure. At the same time, political instability and weak governance created power vacuums, leading to escalating gang violence. As of early 2026, armed gangs controlled vast territories, extending their influence into the capital city Port-au-Prince and the surrounding areas. In total, 1.4 million people have been displaced, and 70% of healthcare facilities have been closed. There's been a drastic shortfall in funding, with only 6% of funding goals met. In a context like Haiti, where economic collapse and health system strain affect the entire country, a narrowly focused program on women living with HIV can be both strategic and impactful. A targeted approach ensures that limited resources can be directed to where they have the greatest effect. Women living with HIV face compounding vulnerabilities, gender inequality, and the stigma of HIV. Vulnerable populations like women living with HIV are often missed in broader, less specific interventions. Haiti accounts for 38% of new HIV infections in the Caribbean. Women make up a majority of the 130,000 adults living with HIV, and HIV prevalence in women is nearly double that of men. Women face significant gaps within the humanitarian space, shaped by structural inequalities, conflict, and disruptions in service delivery. One of the most critical barriers is a lack of access to care. Despite having one of the highest burdens of HIV in the Caribbean, many women struggle to reach testing, treatment, and follow-up services because of distance, cost, or safety concerns. Gang violence and internal displacement restrict mobility, resulting in missed opportunities for HIV prevention and treatment. Beyond physical access, there is a gap in peer support and psychosocial services. Humanitarian response tends to prioritize immediate medical needs, often overlooking community support networks that help women cope with the stigma, trauma, and long-term treatment of HIV. For women with HIV, the absence of safe peer spaces exacerbates isolation and undermines sustained care. Fragmented services create further challenges. In Haiti, sexual violence correlates with HIV transmission risk, yet services addressing these issues are often siloed. Survivors of gender-based violence navigate separate systems for HIV testing, retroviral therapy, and psychosocial support. This creates unnecessary delays in care. The lack of coordination between HIV and gender-based violence programs reflects broader weaknesses in humanitarian health systems and reduces the effectiveness of interventions. Lastly, women with HIV are frequently excluded from decision-making processes that shapes the humanitarian response. Despite being directly affected, they often have limited voice in the design, implementation, and evaluation of programs. This leads to programs that do not fully reflect their lived experiences, such as the need for confidentiality, locally based care, or integrated services. Limited access, weak peer support, siloed services, and exclusion from decision-making highlight the need for more inclusive and integrated approaches in the Haitian humanitarian response. To address these systemic failures, this program proposes a new framework: recruiting, training, and employing women living with HIV as community health workers. This peer-led model leverages the lived experiences of community health workers to build trust among other women living with HIV and deliver health services directly to vulnerable populations. The objectives of this program center on 4 main pillars. The first pillar is empowerment. Women living with HIV will be recruited from displacement camps and high prevalence neighborhoods. They will be trained in HIV education, sexual and reproductive health, and identification of victims of gender-based violence. Secondly, community health workers will work within their own communities and displacement camps to conduct peer education. They will conduct home visits to educate other women about HIV prevention and reproductive health while maintaining patient confidentiality. Community health workers will be equipped to perform rapid community-based screening with HIV self-testing kits and preliminary screenings for sexually transmitted infections. Any at-risk patients will be referred to primary health clinics for additional support. The next pillar is adherence. Considering clinic closures and supply chain disruptions, community health workers are a vital link between patients and the fragmented healthcare system. They will monitor antiretroviral therapy among other women living with HIV, deliver medications directly to those unable to travel to clinics, and provide ongoing psychosocial support. Finally, we emphasize advocacy. A secondary gain of the intervention is it positions these women as community health care leaders. The program creates a collective voice for women's inclusion in local governance and humanitarian planning. The deployment of community health workers is a well-validated strategy in global health, particularly in low-resource settings. In Haiti, organizations like Partners in Health have demonstrated that task shifting is highly effective for scaling up HIV services. Task shifting is the transfer of specific clinical and educational duties from nurses and doctors to trained community members. Peer education models are particularly important. When women living with HIV serve as health workers, they bring empathy and understanding to their roles that are both contextually and culturally relevant. The shared identity of community health workers and the community reduces power inequalities, overcomes social stigma, and improves linkage to care. Peer-led interventions increase medication adherence and result in higher rates of undetectable viral loads among patients. Employing women with HIV can break the cycle of poverty by providing stable income, improving access to health care, and empowering the women to make decisions about their own health. Economic inclusion also helps reduce inequalities by challenging societal norms about women in employment, increasing workforce participation, and fostering equitable community development. Our program design aims to employ 100 women living with HIV. They will be recruited from displacement camps and high prevalence neighborhoods. They will undergo culturally sensitive training as professional community health workers. Our target is to reach 10,000 women to provide decentralized screening services for HIV and other sexually transmitted infections, education about sexual and reproductive health, and identification of victims of gender-based violence. At-risk patients will be referred to appropriate services. Our target for HIV aligns with the World Health Organization's 90-90-90 goals. 90% of women living with HIV know their status, 90% of those diagnosed are on antiretroviral therapy, and 90% of those on therapy have successful treatment with undetectable viral loads. A second, unmeasured goal of this program is to recognize women as health leaders. By selecting 100 community health workers, we aim to put women living with HIV in the center of policymaking for their own health and for future humanitarian programs. With escalating gang violence, the safety of community health workers is our primary concern. The program will implement strict security protocols. First, community health workers will only operate within their immediate familiar neighborhoods to avoid potential gang territories. Local deployment will minimize travel through unfamiliar areas. Second, the identity and health status of both community workers and their patients will remain confidential to protect sensitive information from being released to family members, friends, or other community members. We will integrate with mobile health services for continuous monitoring. A secure, mobile-based communication system will allow for immediate feedback for any safety concerns and for data collection. Lastly, we will partner with other health service organizations for flexible care. When possible, we will rely on local supply chains for distribution of medication to reduce travel risks for community health workers and patients. Monitoring and evaluation will begin immediately upon program implementation with independent third-party consultants. We will measure for both clinical and social metrics. We will look at primary health data of the treatment area compared to the surrounding regions, and we will conduct surveys and focus groups within the community to measure the perceived impact of the program. We will look at the number of women screened for HIV and sexually transmitted infections. We look at the percentage of identified women living with HIV who were successfully linked to treatment programs. We look at antiretroviral therapy adherence rates and the incidence of mother-to-child transmissions. We will also examine some social metrics, including the number of gender-based violence survivors referred to safe spaces and specialized care, the total number of home visits conducted, and we will assess for any economic impact for the community health workers because of direct employment, or any perceived reduction in the stigma of living with HIV because of their leadership positions within the community. This program is expected to yield results across multiple sectors. First, health resilience. By decentralizing care, the program mitigates the impacts of international funding freezes and regional clinic closures. We project a significant reduction in disruptions of antiretroviral therapy and an increase in the percentage of women living with HIV to have suppressed viral loads. Second, economic empowerment. By employing 100 women living with HIV, we provide direct economic relief to vulnerable households, disrupting the cycle of poverty that drives transactional sex and further HIV transmission. Thirdly, community buildings. Positioning women living with HIV as essential stakeholders negates the stigma associated with the virus. And lastly, humanitarian policy. The program demonstrates that empowering marginalized women can be an effective strategy for building health system resilience in conflict-affected regions. In conclusion, empowering women living with HIV as community health workers in Haiti is a small response within a much larger health crisis, but it is a strategic investment in the future of the country. By addressing several intersecting sectors of health, gender, and economic inequalities, this program has the potential to create a sustainable impact that reaches beyond the immediate needs of women living with HIV. It is a call to action for stakeholders and other organizations to recognize the value of women's leadership in health and humanitarian efforts. Working with partnership organizations, this program can help build a more resilient and equitable Haiti, where women have opportunities to thrive and contribute to the country's recovery.